Good afternoon, everybody. As Patrick said, my name's Kelly Szelc. I am the inpatient diabetes educator here at Passivant. And today I'm going to talk to you about treatment of diabetes while you're in the hospital. So these are some of the things we're going to cover today. Hopefully you'll be able to define diabetes. We'll be able to identify 2 causes of diabetes. We'll be able to identify 2 signs and symptoms of diabetes. And we want you to be able to verbalize the difference between type 1 and type 2 diabetes. And that you'll be able to determine how diabetes is diagnosed. And then verbalize understanding regarding diabetes treatment in the hospital. So first we're going to have just a little general review about diabetes. So what is diabetes? It's a disease in which your body does not produce or properly use insulin. Insulin is a hormone made in or produced in the pancreas, and insulin converts glucose, starches, and other food into energy. So what are the causes of diabetes? The cause is still unknown, but in type 1, we know there are some genetic and environmental factors that affect that. And also in type 2, there's some risk factors that can lead to type 2 diabetes. So some of those being some high-risk ethnic groups, such as African Americans, Hispanics, Native Americans, or Asians. If you're greater than 45 years old, if you're overweight, if you have inactivity or lack of exercise, if you have a family history of diabetes, or if a woman has a history of gestational diabetes, meaning she has a baby that is born over 9 pounds. If you have high triglyceride levels greater than 250, or HDL, or your good cholesterol, less than 35, you have a history of prediabetes, high blood pressure, metabolic syndrome, or polycystic ovary syndrome in women. So some of the signs and symptoms of diabetes. The first 3, increased tiredness or fatigue, increased thirst, or increased urination. Those are the top signs of high blood sugar and can actually lead to patients complaining of these things to their doctor, can lead to them testing to see if they actually have diabetes. Some other signs and symptoms are blurry vision, slow healing of cuts or wounds, burning or tingling of hands or feet, frequent infections, or unexplained weight loss. There are some different types of diabetes, so we know type 1 diabetes, in this group, these individuals do not produce any insulin. And usually we see this occurring in children or younger adults, and these individuals must take daily insulin injections in order to control the blood glucose. It is considered an autoimmune disease, and 10% of the population has this type of diabetes. In type 2 diabetes, the body does not make enough insulin or cannot properly use insulin. Risks of developing increases with age and lifestyle factors such as obesity or being overweight and lack of exercise. This type of diabetes is managed with diet and exercise, oral medications, and sometimes we also use insulin in these individuals. It usually occurs in people over 40, but we are seeing it in younger populations as well. About 90% of the diabetic population has this type of diabetes. And with type 2 diabetes, we do see a hereditary link. So if you have a family member that has diabetes, the other family members are at risk. Secondary diabetes is usually caused by stress, by a stress on the pancreas, and it's secondary to either medications or a chronic illness. We see this in the hospital, and it can happen during an acute period of medication or illness, and we have to use insulin to control the blood sugar during that time. So how is diabetes diagnosed? There are several different tests that physicians can order for diagnosis. The first one we have the fasting blood glucose. So it's a fasting blood test, and if the result comes back, and fasting meaning you don't have anything to eat, at least for 8 to 10 hours. And if it comes back 100 to 125, they consider you to have prediabetes. If it's 126 or above, then the diagnosis of diabetes is made. Or if we get a blood sugar of greater than 200 anytime throughout the day with symptoms, where you're having symptoms of increased thirst, increased urination, or unexplained weight loss. There's also an oral glucose tolerance test that can be performed. And this is where you drink that real sugary cola fluid. They start off with a 75-gram glucose load. They give you the glucola, 75 grams. And in 2 hours, they test your blood sugar. They do a blood test. And if the result comes back 140 to 199, they diagnose prediabetes. If it's 200 or above, then the diagnosis of diabetes is made. And now we can use the Hemoglobin A1c test as well as a diagnostic tool. So the Hemoglobin A1c measures the blood sugar control over the past 3 to 4 months, and it's kind of an average of your blood sugar. So if it's 6.5 or above, the diagnosis of diabetes can be made now. So now we're going to talk a little bit about diabetes care in the hospital. So hyperglycemia, that's high blood sugar. And in the hospital, it can present in individuals that already have a diagnosis of diabetes, or if they detect it in the hospital by blood tests while you're there, or it can be related to illness in the hospital causing high blood sugar. So it can result from stress, uncontrolled diabetes, if you withhold any of your oral medications or insulin doses, or certain medications such as glucocorticoids, steroids, or prednisone, which can elevate the blood sugar. So hyperglycemia, high blood glucose in the hospital, it's been defined as any blood sugar greater than 180. And low blood sugar or hypoglycemia has been defined as any blood glucose less than 70. Some other blood glucose goals in critically ill patients, like in the ICU setting, 140 to 180 is the goal there. And in non-critically ill patients, the before meal glucose target should be 110 to 140. Some physicians may individualize your blood sugar goals depending on the severity of the illness or in certain surgeries. So our diabetes treatment plan in the hospital with insulin. So in the hospital setting, insulin therapy is the preferred method of treatment for elevated blood sugar levels. In the critical care units, we use intravenous insulin infusion as the preferred method of treatment. Outside the critical care units, there could be scheduled insulin injections at meals or at bedtime. They may be used. Okay, just keep in mind that even if outside of the hospital, if you were on oral medications at home before you had come into the hospital, this could be changed, and you could be switched over to insulin injections in order to achieve blood sugar control and to promote healing. Our diabetes treatment plan in the hospital with oral medications. Oral medications, they have a really limited role in the management of high blood sugar in illness. Sometimes we do continue the oral medications if the patients are stable and if they're eating their meals, or we may even use oral medications in combination with insulin injections. Okay. Oral medications could be resumed or restarted at discharge if the patient is clinically stable and the blood sugar levels are in an acceptable range. We just want to take caution with the drug metformin, because patients that have kidney disease or they have any kind of testing where it requires IV contrast or IV dye, this medication needs to be held. Diabetes care providers in the hospital, it's a team approach. So there's a lot of different healthcare providers that are involved in helping to manage your diabetes when you're in the hospital. You may have your primary care physician who is managing the diabetes, or an endocrinologist may be consulted. If you don't have a primary care physician, a hospital list may be assigned to you. You may see a nurse practitioner, physician assistants, pharmacist, nurse, nursing assistants or patient care technicians, dietitians, and also the diabetes educator. So all of these people work together as a team to help to manage your diabetes while you're in the hospital. Some more on the diabetes treatment plan in the hospital. So insulin injections, we use them before meals and at bedtime. These may be ordered. We said oral medications could continue to be used, and sometimes in combination with insulin injections. Blood glucose monitoring, we may do this more frequently. A lot of times we do it before meals and at bedtime as well. And then a consistent carbohydrate diet plan is oftentimes instituted in the hospital. And the consistent carbohydrate diet plan helps to control the blood sugar, because we limit the number of carbs that you have at your meal, which affects the blood sugar level. We know when we eat carbohydrates that does make the blood sugar go up. So with a consistent carbohydrate diet plan, we can limit carbs at breakfast, lunch, and dinner, and that can help us with blood sugar control. So if your physician orders a consistent carbohydrate diet plan, a bedtime snack is ordered in the hospital to prevent low blood sugars overnight, because we give insulin at breakfast, lunch, dinner, and bedtime in the hospital. A lot of people don't take insulin at bedtime at home, or the sliding scale or coverage insulin at bedtime. So we give the consistent carb snack at bed to prevent the low blood sugar overnight into the next morning. Typically, this snack is a 1 carbohydrate choice snack, and it can consist of 3 graham crackers, 3 honey graham crackers, a sugar-free pudding cup, or a fruit cup. Okay, if you are a diabetic and you do not receive a bedtime snack in the hospital, it's really important that you ask your nurse about this, because I feel that every diabetic patient in the hospital should receive a bedtime snack, for the reason of insulin at bedtime and also to prevent low blood sugar episodes. Some more on the treatment plan in the hospital. There is a hypoglycemia protocol ordered for patients on an insulin injections in the hospital, or anyone that's at risk for low blood sugar. And this gives treatment guidelines to the nursing staff to treat any blood sugar 70 or lower. The hemoglobin A1c, that may be ordered if it has not been done in the past 2 to 3 months. And you may have consults to certain specialists, such as endocrinologists, dietitian, or the diabetes educator, to evaluate your diabetes and to provide education. And of course, we always refer outpatient diabetes education at discharge, so that you receive additional education about your diabetes management. For insulin patients, do we have any insulin-taking patients in the audience? What do you do at home before a meal? You can shout it out if you test your blood sugar. How do you take your insulin? Okay. Do you take it, so insulin pumps are continuous, but you bolus when? When do you bolus?
I bolus whenever I count my carbs.
Okay.
Bolus, eat my meal.
Okay, good. How about with an injection?
They don't know what bolus means.
Well, in an insulin pump, there's a continuous infusion of insulin over a 24-hour period, and then before the meals, they count their carbohydrates in the meal, determine how much they're going to eat, they program it into the pump, and the insulin pump tells them how much insulin to administer. And there's settings programmed in to help them calculate that information. And then they verify that, and it infuses, and then they eat. So with someone with that does injections, you test before the meal, and you should be taking your insulin right before you eat your meal. So in the hospital, we want to kind of continue that same treatment you do at home. So here in the hospital, a lot of patients do what we call room service ordering of their meal trays, where they pick up the phone and they call down and order their meals at breakfast, lunch, and dinner. Okay, what's real important about this is when we're doing our blood sugars and when you're getting your insulin. So when your meal tray comes to your room, it's really important that you let your nurse know that the meal tray has arrived, because he or she may need to recheck your blood sugar, and they need to give your insulin with your meal. So ideally, the blood sugar should be checked 30 minutes to an hour before the meal. And the insulin and even the oral medications need to be administered at meals in order to prevent low blood sugar episodes. So, we've been doing a lot of work with the nurses and educating them as well. But I feel it's important that you're educated as well about this, so that we can all be on the same page as to what we need to do in the hospital. It's also, I feel, very important that you ask questions. So anything related to your diabetes care in the hospital. So you want to make sure that you ask your nurse, if you start on a new oral medication or insulin, what is it? How does it work? When should you take this medicine? Why was there a change in the medication or insulin? What was your blood sugar? How many units of insulin am I getting? So it's always good to question and to find out what changes have been made in your diabetes management. Hypoglycemia in the hospital, or low blood sugar. So there's lots of different reasons why low blood sugar occurs in the hospital. So patients with diabetes, and even patients that do not have diabetes, develop low blood sugars in the hospital. And we see this through altered nutrition intake, or if they have a decreased appetite or they're not eating, the timing of their blood sugar levels and when they're being done, timing of insulin and oral medications in relation to the meal, in patients that have heart failure, kidney, or liver disease. So what is hypoglycemia? Hypoglycemia, as I said, is low blood glucose, or blood glucose levels 70 or lower. Some patients feel the signs and symptoms of a low blood sugar, and others do not. Some patients have what we call hypoglycemia unawareness, where they don't feel the signs and symptoms. So in those individuals, they need to test frequently. They need to test their blood sugar frequently to make sure that their blood sugars are not running lower. But all the symptoms listed here, these are all symptoms that patients have told me that they've experienced. Shakiness, pounding heart, rapid heart rate, tingling in extremities and lips, sweating, heavy breathing, cold, clammy skin, slow thinking, dizziness, fatigue, or blurry vision, trouble concentrating, slurred speech, numbness, lack of coordination, hunger, headache, nausea, weakness, or just a general feeling of something not right. So in the hospital, we have the Hypoglycemia Treatment Protocol, and that's used to treat any blood glucose 70 or lower. And treatment can include, remember we had said no orange juice for treatment of low blood sugars, and just to reiterate that, because of the kidney disease. So in diabetic patients, they're at higher risk for impaired kidney function or kidney disease, so we don't want to administer orange juice for those patients. Instead, we prefer 4 ounces of apple juice, 6 ounces of clear soda, or a tube of glucose gel. If you're not eating and you develop a low blood sugar in the hospital, or for some reason you would become unconscious from a low blood sugar, you would receive intravenous glucose or intravenous fluids with glucose, or a glucagon injection. So diabetes education in the hospital involves learning basic survival skills of diabetes management for home. So if you're on a new oral medication or insulin, it's important that we give you education about what it is and how it works and when to take the medication or insulin. If you're new to insulin injections, then we need to give you instruction on how to do the insulin injection for yourself, where to give your injections, storage of your insulin, and disposal of your needles. We need to give you education regarding high and low blood sugar signs and symptoms and what to do for both. Blood glucose monitoring. If you're not monitoring, we want to make sure that we get you a blood glucose meter and show you how to use that, and talk about how often you should test and the goal for your blood sugar. And then sick day management, what to do when you're ill, what to do regarding your medications and insulin, and some foods that you can eat while you're not feeling well. And then, of course, I always refer patients to outpatient diabetes education after discharge to reinforce what they've learned and also to learn some new information. Diet education in the hospital is provided by the dietitians. So the dietitians assess your clinical condition, eating, lifestyle habits, and then they determine a realistic diet plan for you. And as we were saying, they teach about the consistent carbohydrate diet. So if you are placed on this diet plan, we do consult the dietitian to come and talk to you so you understand about how to select your carbohydrates. The dietitian will also provide education about the diet, review carb sources found in foods, and will help you individualize your diet plan. And then they will also reinforce outpatient diabetes education for diet to reinforce what you've learned and to learn more about your diet and meal planning. Discharge planning. So it's recommended that the following areas are reviewed with you and addressed prior to discharge. So we want to make sure that you understand who you're to follow up with, your healthcare provider after discharge, and who will provide your diabetes care after discharge. We want to assess your level of understanding related to the diagnosis of diabetes, that you understand blood glucose monitoring and your blood sugar goals, that you understand the definition and recognition, treatment, and prevention of high and low blood sugar, that you have information on consistent eating patterns and your consistent carbohydrate diet, and when and how to take oral medications and insulin administration if you're going home on insulin. Sick day management again, and proper use and disposal of needles and syringes. It's also important that you have the proper medical equipment, medication, supplies, and prescriptions at discharge. So we want to make sure that you have a prescription for your insulin, whether it be in the vials or the bottles, or the pens, if you're being discharged on insulin, or syringes or pen needles to administer it, again, if you're on insulin. A prescription for your oral medications, a blood glucose meter, a prescription for blood glucose test strips, a prescription for lancets for blood glucose testing, and in type 1 individuals, they need the urine ketone strips. In case their blood sugars go really high for whatever reason, if they go 240 or higher, they need to test for ketones because that tells them whether they're going into diabetic ketoacidosis. So they need to have those on hand. Diabetes self-management education. So why do we need diabetes self-management education? So this is really important to learn more about diabetes after discharge and to help keep your blood sugar in good control, and also to help prevent complications. So we recommend the outpatient education for all newly diagnosed patients or patients with high blood sugar at least within 1 month after discharge. There are classes and one-to-one education sessions available. The classes cover basic diabetes knowledge, monitoring and guidelines, health recommendations, review of medications, stress management, sick day management, travel considerations, nutritional class, physical activity, complications and goal setting, and they will evaluate you again in 3 to 6 months after the classes. In the one-to-one sessions, nutritional counseling is offered, meter education is offered, and insulin and injectable medication training. Most insurance plans do cover outpatient diabetes education, but it's always important to check with your particular insurance plan to make sure that it is covered. It is a covered service. And here at Passivant, I have the class information and the dietitian information. If you're interested in scheduling a session for the classes, it's 412-367-5065, and the dietitian 412-367-6398. Does anybody have any questions about diabetes in the hospital? Somebody down front here.
Regarding feeding in the hospital,
Yes.
can at UPMC Passivant, can you ask for like a low sodium meal as well, or a low fat diet? Can that be prescribed?
The diet plans can be modified. So if, say, your doctor wants a consistent carbohydrate diet and a low sodium diet, it can be both. They can order it that way. Or if you're on a consistent carb diet and a heart healthy diet. So it can be ordered in combination and individualized that way by your physician's order.
I'm on a sliding scale for both Novolog and Lantus. Do I have to have that on my information? I have information on my refrigerator
Okay.
for in case I'm picked up by an ambulance.
Very
Do I
good.
have to have that, the amount that I do, or does that automatically taken care of? Do they follow their own sliding scale depending?
The
I just
hos-
wondered how they did that.
Yes, that's a very good question. First of all, Lantus should not be a sliding scale insulin.
Pardon?
Lantus should not be a sliding scale insulin. It should be a set dose insulin. Novolog is a sliding scale insulin or a coverage insulin. But yes, there are specific sliding scales that are ordered in the hospital that are set and that the physician can choose. So we have what's called a low dose sliding scale, a moderate dose sliding scale, and a high dose sliding scale. And so which one they select is basically depends on your blood sugar control and what other medications that you're taking as to which one they'll select for you while you're in the hospital. But it could be very different from what you do at home.
Okay, thank you.
Just to add on to Kelly's comments a little bit, any medications that you're taking, even if you're using a sliding scale, make a photocopy of that scale and stick it in that little holder. I know the holders you're talking about, they're stuck on the side of your refrigerator that they just pull it. Because it gives us an idea when you come into the hospital of how you were treating your diabetes before. So we can build that into our plan through the hospital to get you back to that. Okay? Any other questions? You guys are either really good or really tired,
sleepy.
or you're cooking off your meal, huh?
Sure. There you go.
When you go into the hospital and your medications change from oral to insulin, but then you're discharged back to regular oral medications again,
Sometimes.
will they ever change it back to straight insulin and then discharge you back on insulin again?
It could happen. You know, in the hospital settings, they use insulin because it gets the blood sugars more into the goal range where they want more quickly.
Or do they just consult with your PCP also about that?
Yep. So PCPs do manage it in the hospital, and sometimes they consult the endocrinologist to come, especially if you have lots of other medical conditions that they feel that the endocrinologist needs to be involved to help with your treatment plan.
Okay, thank you.
All right. And the gentleman brings up a great point. If we change your medications in the hospital, it's not because something's wrong with your diabetes, it's because something's wrong with the hospital. By that I mean, are you as active as you are at home when you're in the hospital? No. Do you eat the same as when you're in the hospital? No. All right, so some of the medications that we use on the outpatient side, like Liburide, Glipizide, Glimepiride, Glucotrol, Amaryl, those drugs are all related to a very high rate of low blood sugar. We don't want you to have a low blood sugar. It is much more predictable and much safer for us if we use insulin on you in the hospital. Beside the fact, we know exactly if we give you insulin, when it turns on, when it's working the hardest, when it's gone. Okay? I can basically give every one of you 1 unit of insulin in here, and I can guesstimate how low I'm going to lower your blood sugar. But on the inpatient side, when you're NPO for tests and you're not eating correctly and you're not up and moving around, sometimes that puts you at a risk of developing a low blood sugar. Kelly and I look at the low blood sugars every day. On an average month, we have 120 people that have low blood sugars. That's a lot of people. Okay? So we try and change the medications a little bit as far as making it safer for you. Plus, some of the medications don't play nice together. Okay? Insulin does one thing, does it well, lowers your blood sugar, doesn't interact with too many other medications. So it's better for us, and it's better for you. Okay? Any other questions? This is the quiet I've seen you guys all day. Oh, wait a minute.
If you're taking Lipitor for your cholesterol, how does that affect at all? How does that affect your diabetes medication? Or doesn't it?
I don't think it really affects the blood sugar that much. I mean, it has its own side effects,
Yeah.
but I don't think it has a major effect on the blood sugar level.
Lipitor has nothing to do with diabetes, except, are diabetics heart patients? Yes.
Yes.
Absolutely. At diagnosis, you're put in the same risk category as a non-diabetic who has survived a heart attack. So even if you haven't had a heart attack, we know that diabetes is a cardiac disease, all right? So many diabetics are on cholesterol medications. They have nothing to do with blood sugar. They just lower your bad cholesterol and your triglycerides and so forth, all right? So there's no interaction that we need to worry about. There's actually a lot of literature out there that says diabetics should be on cholesterol medication, blood pressure medication, anti-diabetic medications, baby aspirin every day, because that's what we do for heart patients too, is we put them on a baby aspirin, we control their blood pressure, we control their cholesterol. So you got to look at the whole picture when you're looking at medications, and that's why it's really good that Kelly put up there that you should ask what medicines you're on. Okay? This isn't the days of our grandparents, guys, where they gave you a pill and you took it and you never questioned it, because some of those pills, like Carter's liver pills, were cyanide. Okay? So you got to ask what they do, because you're 95% of the management team. You are the driver of diabetes, not the nurse, not your doctors, not your wife, not Joe down the street, not your dietitians. We can all give you information, and we can support you, and we can give you advice. But once you walk out the door, you're the manager. So 99% of the time, you're on your own. Really important to talk to those other people, but you have to have the information. Okay? That's the other great thing about outpatient education is, guess what? We have the time to talk to you. Your physician doesn't. Many nurses in the hospital. How many people have been in the hospital with diabetes? When did you get your education? Mostly after, like right when you got all your clothes on and your ride sitting at the door, right? That's the wrong time to teach you, because your focus is one thing. I've been here for 4 days and I want to fart out. You're not going to hear a word that Kelly says, or I says, or the dietitian says, or even if your doctor comes in and says, guess what, we don't have to send you home on insulin. Because we've had people call and say, they didn't give me a prescription for my insulin. All right? It's the wrong time. So on the outpatient side, we have the time and resources to pound through all of that information and help you manage your diabetes. Okay? Any other questions?
Aha.
You just had to make a fat man run.
Can you take chondroitin and glucosamine when you have diabetes?
Okay. I just want to know if there's anything food-wise or otherwise that can help decrease the side effects from metformin.
Well, in certain cases with metformin, it can cause stomach upset and diarrhea, and sometimes it's the way you take it which can minimize the side effects. Making sure you take it with food, and a lot of times we start that medication slowly and titrate the dose up slowly because of that risk. There's also extended release formulas that don't have as much of a side effect.
Well, excuse me, I'm speaking not for myself, but for my son. And he was put on metformin and got to the highest dose that he was taking twice a day. And I guess he just really started to have the side effects subside, and they put him on extended release, and he's having terrible problems. But beside the upset stomach, he feels bloated, and it's just, he's miserable.
Some people can't tolerate it, even if they do switch them to extended release. So it's always important to let your doctor know that you're having these problems so that they can either change you to something else or maybe cut the dose back some to the dose before where he was not experiencing, or add something else to help.
Okay, well, he is taking another, the injectable
Okay.
as well. No, it begins with a V.
Victoza?
Yeah. And that has the same kind of side effects, doesn't it?
It can't. Yeah, Victoza is one of the medications that it's an appetite suppressant. It decreases your appetite. It decreases glucagon production. And some of the big side effects are bloating, nausea, vomiting. But any drug that you're taking, folks, you need to let your doctors know if you're having side effects. Okay? Doctor's not a mind reader. Educator's not a mind reader. So if you're sitting at home and you're struggling with living in a bathroom and trying to find enough comics to read, you got to let your doctor know, because there are other drugs that we can try. See, and that's the problem. Even though new drugs every day are being cranked out through the FDA for the treatment of diabetes. I mean, new meters are coming out. We were just having the discussion outside, Gene Wagner and I, about what are we going to talk about next year, and the topic of new technologies and new drugs that are coming out came up. So there's a lot of options for us, but we don't know specifically. We know what the drug's supposed to do, all right? And generally how much it's going to lower your A1c. That's the bang for the buck. What's it going to do for my A1c? But we don't know what your body's going to do to it, okay? When I start playing that game, then all bets are off. Like, I take very high doses of Motrin because I have bad knees. But if I gave you guys the dose of Motrin that my doctor prescribed for me, you'd probably throw up. And it's just that irritating to your stomach. Okay? So anytime you have side effects from a medication, even if they're an expected side effect, like with metformin, bloating, gas, diarrhea, nausea, you need to let your doctor know. Those should resolve fairly quickly. And maybe it's a combination of the Victoza and the metformin he just can't tolerate. So maybe we got to put him on, an alpha-glucosidase inhibitor like Precoce or Glycet or another insulin-producing drug, what we call secretagogues. That's the glucotrol and the amaro and so on. And get them off the metformin. Although that is the #1 recommended drug for type 2, not everybody tolerates it. Okay? Almost like I knew what I was talking about.
Can you take glucosamine and chondroitin when you have diabetes?
Yes. That was the easiest answer of the day.
I have a question. You mentioned the metformin and IV contrast dye. What happens?
Well, because metformin is excreted through the kidney, and so is the dye, it puts too much demand on the kidney. So we don't want to take those two medications together because it could cause a contraindication.
Yeah,
So it's
remember-
usually held before and then at least about 48 hours after.
I remember Dr. Nyron was talking about lactic acidosis. If you're in kidney failure, well, metformin in the hospital, we find it more common. So we may change you off your metformin, or if you're going for any dye test, or even some of the anesthesias, we'll hold your metformin,
And some,
just to decrease that risk. We know that's the safest thing to do. Even though most of the dyes anymore do not contain iodine, there's new dyes that have come out, we're still not going to take the risk.
right. Some physicians will check your creatinine level as well, just to make sure it's okay.
I have a
before-
question. Sometimes your insurance don't cover all the medicines for your sugars, and that's what my problem is, you know. There's one of the sugar medicines I have to be on to lower my sugar, and my insurance is not covering it, and I don't have the money for it, you know. Unfortunately, I'm out of luck with it. The doctor really wanted me on it, you know, and they won't accept it. And sometimes that's just the way the breaks go, you know, with meds, you know. Some meds you can't afford, and some meds you could, you know, and that's a shame. You know, I just wish they could cover it, you know, that way it could help me.
Unfortunately, if you haven't noticed, guys, diabetes isn't cheap, right? Every test strip, $1. Insulin therapy, $170 a month. Januvia, $170 a month. Even people are paying for metformin. Does everybody know you can get metformin for free at Giant Eagle? And you can get a lot of the older drugs like glyburide, glipizide, glucotrol, so on, for free at Giant Eagle? All right? Now, if it becomes a financial burden for you for this medication, you got to have that discussion with your doc. All right? If it means that you move to insulin therapy, that's okay. It doesn't mean your diabetes is bad, because what should everything that we do for a diabetic be geared towards? Lowering your blood sugar without lowering your wallet. It's expensive enough, right? So just because somebody wants you on a drug, you need to have the conversation with them of, you know what, I'm coming up to this choice, and I hear this from people all the time. I either eat or take my pill. But if you don't eat, you're not going to control your diabetes. But if you don't eat and you take your medication, you're not going to control it. I mean, it's a catch-22. So you really have to have that discussion with them, and you are to work collegially with your doctor. You do not walk into a doctor and say, I just ain't going to do it. Because I can tell you what the doctor is going to say. There's the door. All right? So you have to work with them. But you have to have that conversation. And if it is a financial burden, they need to understand that, and they need to work with you to get you into an affordable arena.
Remind people that they can contact the pharmaceutical companies. A lot of the pharmaceutical companies have lots of different programs out there, and some of them are income dependent, some of them are not, or are very reasonable about how much money you can make, and also get the benefit of free or reduced price.
Yeah, and you're absolutely right, Kath. So most pharmaceutical companies do have programs to help people out afford their medication. The problem is, a lot of those are based on if you're eligible for insurance. And if you're eligible for insurance on a prescription plan, you're disqualified. But it's worth the phone call. It's an 800 number. Okay?
Yes. So I was wondering, is there such a thing as a too low of an A1C reading? Because like I got one time of 5.7, and I thought since that gives you an average reading of your daily readings, would it be an indicator of too low blood sugars over that period of time?
All right, which one of the two of you want to do that one? I know the answer, but...
Well, your blood sugar, I mean, it's a good A1C, but are you having frequent low blood sugars?
I wasn't
Okay.
when I was having that.
Okay. So that's good.
Yeah.
But sometimes people do have a pretty low A1C, or they get it really low, and they're having frequent low blood sugars. And that could mean they need an adjustment. So we don't want you to have frequent low blood sugars either.
Does everybody understand, everybody know what an A1C is? Everyone understand an A1C? No, all right. I got a big boomer voice, sorry, I don't need the microphone. So here's the deal. A1C is a more accurate way for us to look at your blood sugar, because it looks at your blood sugars over 3 months. So that 10-inch round cake that you put in your mouth 2 months ago shows up on your A1C. But we all study for a test. When we go for our blood work, we fast. So everything being equal, our blood sugar should be the lowest in the morning. But that A1C, that 3-month average, tells us exactly what's going on. For instance, I was talking to a lady outside that her blood sugar was 90. But her A1C worked out to be 10.5. No, that's not high. Trust me, that's average day in our office. We see 16. All right? So when we're doing things for patients, we want to decrease their A1C. Some people do that and don't realize it, because an A1C is simply an average of all the high readings, all the in-range readings, all the low readings. So if this young man is having 100 lows, it's going to lower his A1C. So that's why Kelly asked the question of, are you having a lot of problem with lows? People between 5 and 6, that's the first question you're going to get out of an educator. How many lows are you having? Are you having a problem with low blood sugar? I'd rather your A1C be closer to 6 if you're having a lot of lows and getting closer to 5, not 6. Okay? Answer your question?
Yeah.
Thank you.
Thank you.
What is reverse diabetes?
Huh?
No such thing.
Reverse diabetes. Never heard of it, so you tell me.
Well, I thought that's when your diabetes was gone.
It's controlling diabetes. It's controlling diabetes. Please.
Doesn't go away.
Everyone say it after me. I can control my diabetes. Right? Perfect. It never goes away. You can reverse maybe some of the side effects. You can limit the extent of damage that the diabetes is doing. You can limit your blood sugars. All right? If you want to consider that reversing your blood sugar, reversing your diabetes, going from a blood sugar of 600 to a blood sugar of 110, okay, but you need to understand that you are still a diabetic. Even if you have an A1C of 5.7 and normal is 4 to 6, you're still a diabetic. Okay, that's why I jumped in on Dr. Nyron, because he was saying you can reverse diabetes. Well, you can control it. You can limit the amount of damage that it does. But you're still a diabetic. There is no cure today for diabetes. Yeah.
Okay, so that's good. You know what, and it's right with, I'm allowed to, with the question that I asked you earlier. When does the body say that you are a diabetic? Is it different for different people?
What'd you say?
When does the body say that you're a diabetic?
Through
Does
blood
your body tell you're a diabetic?
signs and symptoms?
Well, signs and symptoms. Okay, I'm over 50, so I go to the bathroom a lot. Right, guys? Right? I'm working long hours. I was here at 6 o'clock this morning. I'll probably be still cranking at 11 o'clock, and then I'm back for a 6 o'clock meeting tomorrow morning. So I'm tired. Right? You're yawning. Right? I'm always hungry. I'm losing weight. Hey, let's face it, we live in Pennsylvania, so we go from 90-degree weather to 40 below. So we're all walking around doing one of the itchies, right? So, but those, and we're thirsty, so we're walking around. And any person with a half common sense says, well, if I drink 500 gallons of water, it's got to come out sometime, right? So the symptoms are very subtle, and that's what makes diabetes so dangerous. But there is definitive diagnosing criteria for diabetes. If we do that 3-month test on you and you're above 6.5, you are a diabetic. If I do a fasting blood sugar on you and you're above 126, you are a diabetic. If you fail a glucose tolerance test, you get 2 readings over 200, you are a diabetic. It's black, it's white. All right? So I have to ask the question, since this young lady leaded me into it. How many of you are borderline diabetics?
No.
Okay, how many women had babies in here? Please put your hands up, moms. Were you ever borderline pregnant? No such thing as borderline diabetes. You either are or you aren't. You can certainly be a pre-diabetic. That is a risk factor for developing diabetes. Okay? It does not mean you're a diabetic. It means if you don't do something today, you may become a diabetic. Okay? Next question.
I just bought a book and paid $60 to find out how to get rid of your diabetes in 30 days. Did you have?
Oh, no.
I haven't read it yet.
Take it back.
I'm sorry, I know this young lady. So, Jean? No. No, 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 no. I don't care what the chiropractor says, your PCP says, another educator says, a dietitian says. If a dietitian tells you that, they're not a dietitian. Okay? No. Absolutely not. You will never get rid of diabetes. Never. Okay? Even if we do bariatric surgery and we take 2/3 of your stomach out, your diabetes, the term that they used to say they cured it, now they're saying they put it into remission. Okay? There's no cure. Take the book back, get your freaking $60 back. Use it for your Tragenta. Okay? Oh, go ahead.
Is it true that if you have large babies that you will become diabetic, or that?
Why are you looking at me? I don't my baby.
You have the risk. You have the risk of developing diabetes.
Yeah, we survey women and we ask them a couple questions when we go out and do screenings. Did you have gestational diabetes? And gestational diabetes is how your body reacts to stress. Why are you falling asleep now? Is how your body reacts to stress. It shows us that your body's not using sugar correctly. And the second question we ask them is, did you ever have a baby over 9 pounds? Because there is a correlation of about a 10-year onset of type 2 diabetes in women. Let's say yes to those.
Is it really true that a lot of times diabetes follows traumatic events in your life? I mean, really?
Stress.
It can. Certainly it can. So if I put a 500-pound silverback gorilla in here and I lock the doors, is your... Okay, let's do it this way. If I lock you in this room with Pat McCarthy on a really bad day, and I stress you out, what's going to happen to your blood sugar? It's going to go up, right? Now, how our body handles that and what that rise is can cause secondary diabetes. It can diagnose you with secondary diabetes. So we have people that go for cancer treatments, and they get chemotherapy, and they get radiation, and they've just got this wonderful news that they have the big C, right? Oh, we can cure cancer, but we can't cure diabetes. So they're all upset about having diabetes, and they're not so worried about their cancers, right? But it's stress. Stress can make your blood sugars go up. We see that with people that come in. Kids used to die from asthma attacks. Now we give them steroid inhalers. That will raise their blood sugars. Okay? So traumatic events in your life, prolonged stress in your life, absolutely. Worrying about where you're going to get your money for your medication, where you're going to get your money to pay the bills, put food on the table, what's going to happen to the kids when you send them to college, that's all going to raise your blood sugar.
But see, that's what I think is missing in, I don't know how to say this, but I'm just going to say it.
Just say it.
When you have all kinds of different stresses in your life,
Yeah.
even though they are not necessarily your personal stressors, but they involve you, no one that you go to, I mean, you know, like you go to the doctor and you go to the endocrinologist and you go to the
cardiologist and you tell them this, and they say, well, you have to manage your stress, you have to manage your stress. And I understand that. But nobody really tells you exactly, they don't really give you tools. I mean, they'll say, well, this might be a good idea, and that might be a good idea, and this might be a good idea. But they don't really give you a guideline. So you deal every day with this and every day with this, till you get up here and you say, I don't really give a. And then where do you go from there? I mean, and that's what happens. But people don't tell their doctors that, and I know that it happens because they tell me lots of times, but they don't go tell their doctor.
So who?
Then when I go in and I tell my doctor, I feel like a freak. You know, I mean, I feel like, is there something wrong with me? You know? I mean.
See, but you're right. You're right, because everybody thinks, oh, I'm going to get labeled as a nut or a fruitcake or a banana or I'm wacky or anything. But there's something that we don't list on the inpatient side as part of your team. There is nothing, ladies and gentlemen, wrong with talking to a psychiatrist, psychologist, a counselor, a social worker. They can give you the tools.
No, they don't give you the tools either. They give you, well, what do you think about that? They don't give you the tools. I mean, I'm sorry.
Yeah, you need a different psychiatrist because mine will tell me.
I mean, really and truly,
Yeah.
you know, it is a funny.
Yeah.
And then you go to the doctors, and she sits down and you talk to her and you say, I'll really do better next time. Then you go home and some doggone traumatic thing that has
Yeah.
nothing to do with you shakes you all up, and you're right back where you started
Yeah.
from. And every time you go, you feel like the world's biggest failure, and you don't want to go.
Right, and please, don't feel like a failure, guys. You know, the best you can do is the best you can do. You can't do any more. We're all human. We're all going to have those fall downs. We're going to all have days that just think. You heard Kendall sit up here and say there's days he just ain't going to think about it. Now, did you see the size of that boy?
Yeah.
I'm not going to tell him he's not allowed to have an off day, all right? But you're right. But going to a counselor or a psychologist, they can help you understand why you're stressed out. I mean, I sent my 17-year-old daughter out to a psychiatrist. 17 years old. You know why I sent her out? Because she got to march in the Tournament of Roses parade, and she was all stressed out that 8 billion people are going to be watching her. I asked her how many of those 8 billion people she was ever going to see again. She's like, none. I was like, done. Okay? So but you got to find ways to deal with stress. Me, guess what? This is my stress reducer. I love this. All right? So you got to find something that helps you reduce stress. Yes, ma'am.
I take metformin, and I know you're supposed to take it with food. I would like to know, why do you have to take it with food, and are there better foods that it should be taken with that would make it more effective?
Well, we take it with food because it works with the food that you're going to be eating. It does minimize the side effects if you do take it with food. If you take it on an empty stomach, you're going to have a lot more problems with the side effects. Foods, now, we want to, like we've been saying today, I mean, you want to watch your carbohydrate intake. That's going to make a big difference in your blood sugars. And so I don't know, not a particular food, I would say, would minimize the side effects. But some people take it right before they eat. I've had patients start their meal a little bit and then take it once they have a little bit of food in their stomach, kind of to cushion it so that they don't have side effects. But I wouldn't take it after a meal, usually before.
Yeah, any of the medications, if you take it after a meal, you miss part of the benefit. Because part of the benefit is to lower that rise of blood sugar after you digest your food, because everything turns to sugar, right? Carbohydrates, 100%, proteins turn to sugar, fats turn to sugar, your free veggies, fine, nothing, all right? But if you take it after the meal, you're losing the effect. And metformin takes about 2 hours to turn on. If you're taking it twice a day, breakfast and dinner. If you're taking it once a day, largest meal of the day. That's generally dinner for everybody, so we tell people take it with your dinner meal. All right? You do not want to take it at different meals throughout.
As you've shown today, education is the key. But what I was thinking is, what type of programs would you recommend to school systems so that you can deal with adolescent obesity to prevent some of these issues instead of waiting till you get to our age and then talking about them?
Well, but see, our age, that just sounds funny. I just had a birthday. Thanks, dude. Our age environment is much different than kids today. All right? It's not just the schools. It is not. Certainly schools have to improve. All right? Isn't it ironic that Pennsylvania passed a state law that pop machines aren't allowed to be turned on between the hours of 7 and 2:30? What? I never had a pop machine when I went to school. I mean, even when I was in high school, go try and find a Coke. All right? You couldn't. And they limited physical activity. But just the society today, kids are so technologically advanced, they're texting, they're using their computer. They're not writing a term paper, they're typing a term paper. You know, they're not walking next door to talk to Billy, they're Skyping them. So it's an entire societal problem. It's not just the schools. Oh, trust me, those school lunches could improve. Physical activity program. When I graduated from high school, and probably you, sir, since you look a little younger than me, you know, you had to pass, but you had to pass gym to graduate. My daughter has gym 6 months, that's it. So there are things that they need to improve, and they are looking at it, but like anything else that's bureaucratic, it's going to take a while. So when you have, if you have kids, if you have grandkids, here's the thing. Kick them off their cell phones and make them go kick a ball. Make them ride their bikes. Make them play. Take them for a walk. I drag my daughter through the woods. Okay? You just have to make them more active, and you have to make them understand that this is the way life is supposed to be. It's not supposed to be sitting down. My daughter would eat spaghetti 5 days a week. The other 2 days, she wants pizza. All right? So what's the serving on spaghetti, guys? For one carb choice? And the dietitian said what?
1/3 cup.
1/3. So I'm not going to really make you do this, but whoever said a half cup, raise your hand. No. Okay? That's the old recommendation. It's 1/3 cup cooked. All right? That's not a whole lot of spaghetti. I can tell you that my wife's 12-inch plates hold a whole lot more than 1/3 cup, and my daughter heaps it. All right? So we have to put limitations on her and say, you can have spaghetti 1 day a week. That's it. But a lot of parents, it's the path of least resistance. So they get spaghetti 5 days a week.
Because it's
Okay?
easy.
So we just can't blame the schools. I'm sorry, I feel like it's a Pat McCarthy show here.
It's all right.
For people who are taking insulin, could you give some recommendations on any foods that should be avoided?
Foods that could be avoided. Well, we really want to avoid concentrated sweets. Do we know what concentrated sweets are? Anyone? Candy, soda, cookies, cakes, donuts.
There's no food that needs to be really avoided by any person with diabetes. You could, say do not drink regular soda pop, do not drink sweet tea because it's liquid carbohydrate, but there type 1, type 2 insulin oral agents, there's no food that you need to avoid. It's all about how much carbohydrate you're eating at each meal, and are you eating a balanced meal that's balanced with carbs and proteins and fats. There's nothing magic, no magic food you need to choose or to avoid.
You will never hear Jennifer or Luann say, don't ever eat a piece of cake again. But what's the serving size on a piece of cake? 2 inches by 2 inches by 2 inches, no frosting, 1 carb choice. Add frosting, 2 to 3 carb choices, right? Isn't that what you guys taught me? Yeah, I can only say what the dietitians tell me because nurses are crap with nutrition. All right? But there's nothing you can't have. It's moderation, common sense. You can't sit down and eat an entire half sheet cake and think something's not going to happen. Or we went to St. Louis, honest to God story. Just started in diabetes education. Luann and I go out to the American Association of Diabetic Educators meeting, right? Sales rep takes us out to a steak joint. I'm Irish, English, and Dutch. I will eat a cow before you shoot it, all right? We sit down, and they bring this platter of meat. And there's this beautiful 32-ounce steak on there. Now, there's like 13 of us around the table. The only thing I hear is Luann going, "Psst, that's not a serving." I'm like, really? Are you kidding? It's common sense. It really is. Hey, people ask, do you really just eat a 6-ounce steak? Yes, I do. Hey, it's common sense. Dr. Bergman is here. I've been saved by, well, you've been saved by the bell. All right? One last question.
I guess I'm in denial, like I think maybe some of the other questions that I've been hearing. But I remember reading some time ago that, it's hard to accept this forever thing, that when you have diabetes. Sure. But I remember reading something, I think, that even as a child, sugar begins attaching itself to the cells, and it builds. And as we get older, and then we reach that point that we cross over where I guess the blood sugar is so high. That's when the diabetes takes over. But where I'm lost is that when you lower those numbers, is the sugar still attached to the cell? And is that why we're stuck in there forever? No?
No. I've not heard anything about, sugar attaching to our cells, and it builds up over time, and that's what causes diabetes. It's when the insulin doesn't work correctly and moves the sugar out of our bloodstream that throws you into diabetes, okay? And that's a 10-year process for type 2s. Type 1, it can be immediate, it can be later in life, whatever. The problem is, food is very societal, right? It's very ethnic. I've got a lot of friends who are Italians. They eat when they're happy, they eat when they're sad, they eat when they're joy, they eat when they eat. Irish will sit down in a pub and kill a cow and drink Guinness all day long. So there's a lot of societal and a lot of family. It's comforting, right? What do we all do when we have family over? Huge meal, right? We may not eat the rest of the year, but family comes over for Christmas and we ain't got a bigger house, okay? So it's common sense, and it's just a bunch of things. Society is geared at food. There is nothing normal about Wendy's being open till 2 a.m. and seeing 3 cars with triples and large fries and a 40-ounce Coke. Okay? All right. Thanks, Kelly.